now have the keynote address by Dr. HOSSAM ZIADA, Assistant Professor in Ophthalmology from Azhar University, Egypt. Thank you for coming, sir.
Thank you. Thank you for having me in this prestigious meeting. I will talk today about the relaxed smile and saying to keep a smile, don't smile. And first of all, I want from all my colleagues doing a smile to keep smiling in my face. Yeah? The question all the time, PRK, LASIK, film to LASIK, or smile. This is a question which is always asked about the cases, especially the suspected one, to do the PRK or to go to smile. But after a lot of studies, nowadays we have concluded that all the femto or the flap containing or the cut containing procedures are the same in lowering the cornea biomechanics, and their impacts are almost the same after the different studies in different parts of the world. So about the corneal resistant factor, this study for 6 months follow-up after surgery, they found finally that the preoperative corneal biomechanics changed to almost to the same extent on the 3rd month, the 6th month, and finally the 12th month after surgery. They almost equal in the smile and PRK. And concluded that both smile and LASIK procedures do substantially alter the corneal biomechanical properties, and the degree of tensile strength of the cornea is reduced to a statistically significant extent. So the question, if you have a case of thin cornea or high error, what to do? The same for the corneal hysteresis. The corneal hysteresis is an indicator for the corneal power and the impact of the ablative procedures on this power after surgery. So this study too, concluding the same issue, that in contrast to the stability of the corneal hysteresis and the corneal resistant factor measurements after LASIK, PRK, with mitomycin and without mitomycin, also with the LASIK, they showed that the impact will be greater if you add mitomycin C to the PRK than the mitomycin without PRK first, and finally with the procedure of a smile, the extent of changes is equal in both LASIK and the smile, but to much less extent with the PRK ablation, especially without mitomycin. But actually adding the mitomycin will decrease the power of the cornea for a time, not a permanent change. It may take about 6 weeks to recover from the mitomycin effect. As the mitomycin decreases the fibroblastic activity, which is the main core of the corneal power, due to the collagen and the cross-linking process in the collagen of the cornea. So the mitomycin decreases the fibroblastic activity for a time after surgery, so decreasing the power, but it will recover within 6 weeks after surgery. So we have to stop and think again about that. Don't go for any cut containing procedure if you have any suspicious case. Because all studies about the corneal biomechanical changes after all these procedures alarming us about that. And please remember this term, which will help us about thinking, about deciding our ablative procedures in the different situations. The residual stromal bed is no more considerable alone, but nowadays this term, the PTA, which is the percentage of the tissue altered, or the percentage of tissue ablated is more considered as a safety margin, as a safety indices for your ablation depth. This term was put by Marconi Santiago in 2014, indicating this equation: the PTA equals the femto thickness, the flap thickness plus ablation depth divided by the central corneal thickness. The PTA more than 35% is a very high risk of developing the post-LASIK ectasia, and with 100% sensitivity, it's not apparent there, with 100% sensitivity of more than 40%. So you have to calculate your ablation depth and the flap thickness before going for correction of especially the high errors. If you have a patient with a normal corneal thickness, normal corneal topography and tomography, but the error needs a very large ablation depth, you have to think about that and calculate it first before going to your surgery, and don't pay attention to the residual stromal bed. You may leave an adequate stromal bed which is 300 microns or more, but still decreasing the power of the cornea. For example, if you have a patient with -6 diopter myopia and the ablation depth will be around 80 microns, and the center corneal thickness in this patient is 510. If you are going for LASIK with the Moria, even the X90 blade, you will get a flap thickness of 110. So 110, ablation depth of 6 times 13 or 14, according to the machine you are using, you will find that the calculation of the flap thickness plus the ablation depth will be around 100. If divided by the center corneal thickness, which is maybe 500, you may find that the PTA will be more than 35, will be 38, I think. So if you find that the PTA exceeding the 35, you have to be careful. You have to think again. If more than 40%, you have to cancel, or undercorrect, or go for another procedures like the phakic ILs. So I have a lot of patients which I turn from the LASIK surgery to the femto LASIK, doing femto flap of 90 microns to save more 10 microns to correct me 1 diopter more, or decreasing the ablation depth and increasing the PTA percentage. So if you have a normal cornea but a high error, still you are in risk. Turning back to the smile, in my opinion, it's somewhat a complicated surgery because you have a lot of you have a lot of cut planes. The cap side, the lenticle side. I will skip all these slides because it's well shown by my colleagues about the steps and the operative steps of the smile. As we have a lenticle cut, lenticular side cut, cap cut, cap side cuts, a lot of cuts. What will you do if you have an intraoperative complication as suction loss at the early stage, at the middle stage, or the late stage? And yeah, we have a management plans, but still sticking with our cases. So let's go directly to the post-operative care. After showing the intraoperative complication showed by my colleague, about the post-operative care of the Rayleigh smile, which is shown to our patients as a magic procedure. you will find a very delayed visual recovery. Some of our patients may have 2 weeks or more. Yeah, just 1 minute. Thank you. Will have 2 weeks, 3 weeks, or even 1 month to get a visual recovery and be satisfied. And finally, they are not satisfied because they skipped the PR cave because of the delayed recovery. What to do if you have a residual error? Up till now, there is no solution for the residual error after the SMILE, but you have solutions after LASIK or film to LASIK to correct your residual errors. Then what to do if you need a customized ablation like Contura or like the patients with high cylinder? I know that the newer machines could correct up to -4, but I'm still doubt about that. But even if you have a higher cylinder errors, what will you do with a SMILE? I think you can do a lot with the LASIK and film to LASIK, even with the PRK and the golden procedure, which I consider it as the golden procedure, which is customized transepithelial PRK. Because the customized ablation with the PRK is more profiling, is more giving a very good profile after the PRK than the LASIK, because the flap preposition will reposit, will regain most of the irregularity of the corneal surface. So about ectasia too, the SMILE is not away from the risk of the remaining risk of post-operative ectasia. You have to keep the same indices to decrease the risk of post-operative ectasia, the same exclusion criteria. It is not a solution for high errors and suspected cases. A lot of cases have been reported with post-operative ectasia, and I am from Egypt. And I have my colleague, Dr. Mohammed Tariq Anagar, who was the first one reporting post-LASIK, post-SMILE ectasia in a patient with bilateral ectasia after film to second laser assisted with a small incision lenticular extraction, which is very quickly and very fastly published in the Journal of Refractive Surgery without any waiting list. This case was with subclinical or permafrost keratoconus, and then he went, as they thought at that time that the SMILE will decrease the risk of post-LASIK ectasia in the cases with subclinical keratoconus, but actually it was not. So they shocked with this case of bilateral ectasia after doing the SMILE. Followed by reports by the random one about the ectasia after SMILE. Tariq Anagar started the reporting of that cases, so a lot of surgeons after reporting and started to publish about reported cases of post-SMILE ectasia. Finally, ectasia, which is the most recent, 2017, and we have a lot of other reports about the post-LASIK ectasia, and finally they conclude that a majority of cases of reported ectasia cases occurred in patients with subclinical keratoconus. Have a minute, yes. And finally, for now, we propose adopting the same exclusion criteria used for LASIK in the SMILE procedure until more specific metrics have been validated. So I have to conclude that the film to LASIK is more preferable to me than SMILE. It's more planned. I think it's more planned. I can do just one cut and I can complete safely. I can manage everything about my flap. If I got any flap complications, I can postpone my case and can replan again. But with a SMILE, I cannot. It's more planned and reproducible procedure, more suitable for customized plans. If suspicious cases, both of them will be excluded to do PRK or cancer refractive cancel the keratorefractive procedures and going to the fake ILs. And thank you very much.
Thank you, Dr. Hossam. I also thank all the speakers and the delegates for your kind attention. So we are running short of time. We'll be wrapping up the session. Thank you.